Hi, I'm Alicia Hart, and I'll be discussing overcoming feeding difficulties in the child with ASD. You are watching this because you either work with or live with a child that struggles at breakfast, lunch, and dinner. That means shopping for that child for breakfast, lunch, and dinner. That means thinking about breakfast, lunch, and dinner the night before, and the night before that, and the night after that, 365 days a year. It's not just one meal every now and then. This is every meal. And I know this because I have been there. I have been the one that has had to shop for a child, trying to figure out what I'm going to feed him for the next day, for the next 3 days, for the next week. I'm the one who has sat up late at night trying to figure out how to get him to eat breakfast before he goes to school, or how to get him to eat dinner with the rest of the family. And I have been at every meal wondering, what are we going to do and how are we going to get through this? This is my son. In this next video, you'll see Ewan and how that we got through all of those challenges together. As you can see in that video, every child has a story. Now with Ewan, his has included not only autism, but also something called Eosinophilic Esophagitis, which is a very painful disorder of the esophagus that involves eating certain foods. It's a little bit like a food allergy, but on the inside. And it was only because we utilized a program called food chaining that we really investigated why Ewan couldn't eat. It wasn't as if we just jumped straight into the treatment process. We had to figure out why. So with every child, there is a story, and we need to take the time to know the story behind the child. And for every story, there is a beginning, and for your child that's not eating, or the child that you work with that's not eating, the beginning of this story begins at the table, and sometimes before. So why do we eat? You know, I ask this question a lot of times in conferences, and I'll ask everyone in the audience, why do we eat? And everyone will say everything from being hungry, which is the obvious one, to being bored. You know, we don't always eat just because we're hungry. Sometimes we eat because we have nothing else to do. Sometimes we eat because we're emotional and we're sad. Sometimes we eat simply because it's a social event. So if you'll look at this picture on the screen, you'll see that everyone's really focused on other people in the picture. No one's really staring at their plate and staring at their fork. No one's really sitting there thinking about what they're eating. What's happening in this video is everyone's socializing. So sometimes eating is not about food. It's more about who we eat with and what we're doing when we eat, what we talk about while we're eating. And these are all going to be major challenges for the child with ASD. When we think about the family meal, the meal in and of itself is a story. It has a beginning, it has a middle, and it has an end. There are characters and plot lines unfolding as the meal progresses. There's drama, there's mystery, there's sometimes humor, and sometimes, yes, even sadness. And every person sitting at the table has a different perspective or point of view. If you look at this picture on the screen, you'll see a family. It looks like they're sitting outside for a picnic. If you'll notice, mom is looking at the little boy in the dark blue shirt or light blue shirt, and he seems like he's enjoying that watermelon. And then you have the little boy in the orange shirt that has a rather surprised look on his face as he eats that watermelon. Then you have the smallest child in the dark blue shirt who looks a little worried. Mom's watching one boy, dad's watching the other. Everyone has a different perspective in this picture. Some people look like they're enjoying what they're doing, and some people look like they're a little more concerned. But that's the perspective of every individual at the table for every meal. Just like in any other story, there are elements to this story that includes characters, who's sitting at the table, the relationship between the characters, mom and dad and children. Sometimes mom is the stricter one, sometimes dad is. Sometimes dad is the one that says, you know, you need to clean your plate before you can leave. Sometimes mom says, you know, it's okay, we'll come back to this later. Sometimes mom and dad don't always agree. There's the environment where you have a meal. A lot of us eat the meal nowadays in front of a TV. Sometimes there's TV in the background, sometimes there's a radio in the background, sometimes we eat out, sometimes we have holiday dinners where there are many more people involved. There are different motivations and intentions at the table. Mom and dad may have different viewpoints on that. There's different perspectives, of course, and there's different contexts for every meal. If you look at the picture on this screen, you'll see what looks like to be a family dinner. But it looks like an unusual family dinner because people are a little bit more dressed up. I doubt this is just Monday night at this family's dinner. You'll also notice that there's a turkey on the table. It's probably a holiday dinner. Now, I could say it's probably Thanksgiving, but sometimes we have turkey at Christmas, sometimes we have turkey at Easter. So I can't necessarily say that's definitely Thanksgiving just based off those two things. But if you look in the corner, you'll see some pies on a shelf that look like they're pumpkin pies. You'll see some leaf decorations, so I'm going to go ahead and assume from the context of these clues that this is Thanksgiving. Now this picture is a little bit different. You'll see in the background that it looks like there's a very large roasted hog on the table. There are dishes that I don't know exactly what they are. One looks like rice, one looks like some type of noodles. There looks like to be some meat dishes on here. I'm not entirely sure what's going on. I don't understand the context of this dinner. Once I looked it up though, of course, I knew that this was a holiday dinner in Southeast Asia. It's a very different context. Now we know this because we looked it up. But if you don't have that information, you may not know exactly what to do, what to eat, what's on their plate, what it's going to taste like, what the expectations are of you throughout the entire meal, when it's going to end. There are so many clues that we don't really understand here. So in order to understand food and eating and meals, we have to understand that there is a context. Well, what is context? It is the circumstances that form the setting of an event in terms which can be fully understood. Without context, we interpret. We misinterpret sometimes. Put that in plain language. Basically, context is just all of the clues and all the details that let you know what to do. Most of us are 20, 30, 40, maybe 50, and we have all sorts of details stored in our brain about previous meals and previous holidays, and we know what's expected of us at Thanksgiving, at Easter, at a Monday night meal, at a wedding rehearsal, at a wedding reception. We have a lot of experiences under our belt. Children don't. They don't often understand the context. And we, as adults, take for granted that context, or those set of events, of what we eat, how we eat, and where we eat. All things that children may not understand. Context matters, or else no one would ever ask, what's for dinner? I always say that I always tell people when I do this presentation that when I first was hired here at VCU, my boss, my first day here, she said, tonight let's go out for dinner, let's go to a French restaurant. I immediately started to sweat. I'm the kind of person that likes to eat the same thing at the same restaurant every time I go there. So when she says we're going to a French restaurant that I've never been to, I start to worry about what I'm going to eat. Am I going to know what is on my plate? So I rush back to the hotel really quickly and I look up on the internet this restaurant and their menu. Thankfully, it's on the internet. And I find something on the menu that I can eat, salmon. Pretty much my fear has drained away at that point because I know what I'm going to have for dinner. And we get there and it's fabulous. It's fantastic. It's the best salmon I think I've probably ever had in my life. But there was fear. Because context is something that we have to have in order to feel comfortable at a meal. Before we can learn about food and eating, though, we have to uncover sort of the rest of the story besides what is the actual food on the plate, what are we doing for dinner that night, where are we having dinner. There's a whole lot of other details that we might want to know about. Because before we can teach context, we really must learn that first. The child with ASD didn't become a problem eater overnight. There are elements to this story that we may not really be fully aware of. You really are only going to find out the answers to these by understanding that there's a bigger picture besides food, besides eating, besides I don't like carrots. A lot of times we have to ask why, and we have to ask it often. Why doesn't this child want to eat? Is there a problem that we don't understand? Understanding why really comes down to a lot of factors here. In this screen, you'll see that we have facts, which can be facts about food, facts about where we're going to eat, facts about what we're eating, why we're eating, what are we celebrating. There's facts about communication. There's prediction. How do we know what to do at a dinner? Do we know what to do, what's expected of us? There's pain sometimes. There are social expectations. There's sequencing. How do you pick up your fork? How do you bring it to your mouth? All things that we take for granted. There are sensory issues in the child with ASD. Sometimes there are illness issues that we aren't aware of. As I said before, every child has a story. For the child with ASD, there is a developmental history, there's a medical history, there's a nutritional history, and there is a feeding history involved here. And we really need to uncover everything within each of these 4 areas before we can really understand what's going on at the table. In terms of ASD, obviously with the diagnosis, we are dealing with sensory issues, social issues, behavioral issues, and communication challenges. If we think about sensory issues for the child with ASD, a lot of times we focus on just those 5 senses that we all learned in elementary school. Touch or tactile, visual or what we see, what we taste or gustatory, what we smell or what we call olfactory, or what we hear or auditory. But there are other senses in play here. There are proprioceptive issues, such as where we are in space, knowing where we are, whether we're standing, whether we're sitting, or whether we're jumping around. There are vestibular issues, knowing where the horizon is, being able to sit at the table without getting dizzy. But there finally are also interoception issues, which most people don't talk about. When the world of ASD, people will talk about those 5 senses. They'll often talk about proprioceptive issues. They'll also talk about vestibular issues, but everybody forgets to talk about interoception. And interoception is really just your organs talking to each other and talking to your brain. So without proper knowledge and ability to use interoception inside the body, we don't know when we're hungry. We don't know when we're full. We don't know when we have to go to the bathroom. So for all of us, it's hard to imagine not knowing when we're hungry because interoception works for us. We know when we're hungry, we know when we're full, we know when we have to go to the bathroom. The child with ASD doesn't, and sometimes they often need a lot of help with that. In terms of social issues, children with ASD struggle dealing with anything that involves another person. And guess what meals are? Meals are generally social. We very rarely eat in our bedroom behind closed doors by ourselves. We eat with our parents, we eat with our friends, we eat with people in the cafeteria at school. Automatically, anytime food is involved, it is a social issue almost 99% of the time. So automatically, the child with ASD is already struggling, and it has nothing to do with food. It has to do with the other people around them. In terms of behavior, children with ASD often struggle with repetitive interests, repetitive behaviors. Sometimes they struggle with routine. Some children need to drink out of the blue cup and eat off the green plate every single meal, no matter what, no matter where they are, whether it's at home, at school, at the Ramada Inn, or at the next state over for a wedding reception. We still have to eat and drink out of that same blue cup and that green plate. We don't often understand that because we're flexible. We can eat off whatever plate that that restaurant offers us, or our grandparents have out for the fine meal that we're eating for that holiday. The child with ASD is different though. Those things matter. In terms of communication, we also have to remember that a child with ASD can't always say what they want. That involves children that have very little communication skills, all the way up to children who are highly verbal and speak like little professors. Even the little professor can't always tell us what he wants or what he doesn't want, especially when we're dealing with an environment like the cafeteria or lots of people that are there and there are lots of sensory challenges. Already this child isn't able to communicate the same way that he might be in other areas. If you look at the pictures on this screen, you'll see 3 different meals. If the first thing that you would notice if you were a person with ASD is that there are a lot of people at these meals. It looks like one is a smaller family meal, maybe even just a weekend meal. One looks like a bunch of friends getting together, maybe in a really small dorm room. Another one looks like maybe a wedding reception with a lot of different tables and a lot of different people. For the person with ASD, they're looking at all of the people involved in this and all of the social challenges, and really the food is secondary at this point. You don't even notice the food on the plate if you're the person with ASD. You're dealing with all the other struggles that go into sitting at this table with other people. All of the sounds from the scraping on the plates, from everybody picking up and chewing their food and everybody slurping their soup. All of these sounds and issues go into sitting at this table and being able to eat. In terms of the child with ASD, we also have to think developmental. So besides thinking about communication issues and social issues and sensory issues, we also need to think about being able to predict, be able to sequence, be able to know the facts of a meal. We also need to understand the language needs. Every child with ASD struggles with language in some way, and some are going to struggle more than another. In terms of addressing that, we need to utilize communication strategies such as augmentative and alternative communication strategies. We utilize speech therapy to help us to improve these skills, because if I can't tell you that I hate Diet Pepsi, trust me, I will use behavior as a means of communication and a means to get your attention. We have to understand the sensory perspective. We can't just focus on the food here. We have to focus on modifying the environment to adjust for sensory dysfunction. We have to understand that this child's perspective is very different, certainly from our own. What tastes good to you may not taste good to the child with ASD. What you think tastes very good may make the child with ASD gag. Sometimes we have to utilize sensory programs, we have to utilize occupational therapy to get past these things. But one thing to remember is that your perspective is your own. And at a meal, you can't say, "This tastes great. I love this. This tastes so good." Because for the child with ASD who takes a bite, it may not taste good. So rather than saying things taste good or bad, sometimes a way to describe it is to go through and say, how else did it taste? It tastes crunchy. Sometimes it tastes bitter. Again, It's your perspective. The child with ASD may be tasting something entirely different. You know, sometimes things taste 1,000 times sweeter. Sometimes things taste 1,000 times more bitter. We have to keep that in mind, and when the child tells us these things, we have to believe that that is their perspective. And they may not like the things that you like. We have to adjust for social demands. As I've said many times already, meals are not just about eating. It's a social experience. And for the child with ASD, social experiences are not always easy. So we have to remember that there are social interactions and social challenges that just sitting at a table can cause. Eating is a social event. It's a social activity, so we know we're going to have to adjust this environment for the child with ASD. One of my worst restaurant experiences for my son happened at about 14 months of age. And we were at this little Japanese restaurant, and it was kind of a small restaurant. You know, it wasn't very big, but it was a very busy restaurant. So it was open, and you could see the cooks and the cook line and all of that stuff. You could see them making meals. You could see them chopping. You could hear the knives. You could hear the people talking all around the restaurant. Whenever meals were ready behind the cook line, the cooks would ring this bell, and they would shout out every time something about the meal. I wasn't quite sure what they were shouting. Sometimes everybody in the restaurant would shout hooray or something like that. Sometimes there were birthdays that were going on, and they would start singing and wishing somebody happy birthday. And we walked into the middle of this with our child with ASD, who was very young at the time. And we sat down at a kind of at a corner table, trying to get away from all the chaotic environment of the restaurant. And my son seemed to do okay, as well as maybe one could be expected in that kind of environment for as young as he was. And pretty soon, an older couple came and sat beside us. And they started to interact with a little baby at the table next door. And they started waving and saying hi and trying to talk to him. And when I looked over at my son, I could see him shaking from head to toe. He was panicked, completely overwhelmed, to the point that I thought he might just vomit on someone. So I had to take him to the bathroom, and we had to kind of get away from everyone for a little bit. I thought maybe just a little bit of the quiet time in the bathroom might be able to get him the piece he needed to regroup and reorganize, and it ended up not being enough. We had to leave the cafeteria, or the restaurant entirely, and he screamed for 3 hours after that. So it wasn't just some minor deal. It was a big deal for this child, and it was one of the points where I really said, we need help. We don't know really how to do this. We don't know how to get past this because we don't understand what's happening. Remember, behavior is communication. Behaviors at the table mean something, and they really must be examined, whether you use a functional behavior assessment, whether you use just your own eyes, whether you just sit and observe and take notes, whatever it is, realize that these behaviors are trying to communicate something. Behavioral interventions for feeding issues really only come last, after everything else has been evaluated, and they're really only effective after medical evaluations, physical evaluations, developmental evaluations, sensory issues, and communication challenges have all been addressed. We don't skip forward to just behavioral interventions. We have to check out everything first. We have to make sure this child is healthy. We have to make sure that there's nothing else going on here that's preventing this child from being successful. If we skip any of these steps, trust me, whatever intervention that you use is going to fail. Every child is different. We have to remember that every child's abilities and challenges are unique. The child with ASD doesn't really automatically understand the rules or expectations of meals and eating. We have to explain those sometimes through social stories or visual schedules. Sometimes we have to use hand over hand to show them how to eat, or where to place their food, or where to place their table or their plate on the table. Sequencing strips can also help with this because the child doesn't automatically understand what to do or how to do it. We have to understand that sometimes this is a won't issue, or excuse me, this is not a won't issue, this is a can't issue. It's really hard because sometimes we think that this is just a won't issue, that he won't eat. Sometimes this is a he can't eat issue, and we need to realize that. In this video, you're going to see my son using an augmentative communication device, and he uses this in this little video to show everyone the things that he likes and doesn't like about eating. Okay, try it again. Okay, can you find food for Mommy?
Food.
Where's your eating story? You want to push any of those to show everybody?
When I'm all done eating, I can't go play.
Yep, that's right.
I can't smell my food.
You can smell your food.
Some foods smell funny.
Some foods do smell funny. They still taste good.
Next, we sit at the table.
That's what we do. We sit at the table to eat our food.
Then I will help set the table.
Ouch.
First, I will wash my hands.
You're going backwards.
Then first you wash your hands.
First, you wash your hands.
You wash your hands in the bathroom.
Uh-huh, or at the sink.
I can lick the new food to see what it tastes like.
That's right.
Some foods are bitter.
Mm-hmm. Do you think a tomato's bitter? No.
I can try new foods. I need to take 3 bites of a new food.
Ouch. Who had that?
As you can see in that video, Ewan was using his device to explore all the things that he needed to do at a meal. Now, he may have went backwards in the sequencing of how to set the table and wash your hands and all of that, but all of the information that he needed to know what to do at a table, how to describe the food that he was eating, or how to say, I don't like these things, were all part of his communication system at the time. For the child with ASD, we also need to think medical. We can't just ignore the medical part to this child's life. Just like anyone else, the child with ASD is going to get sick, they're going to be in pain, whether that's from the common cold or strep throat to all the way to issues with more rare diseases, such as what my son has, Eosinophilic Esophagitis. Certainly not all children are going to have that. It is a rare disease, but it's a possibility. Children with ASD do get sick. And if we fail to account for this, we're going to miss a very large part of this child's life. I always tell people there are 3 words that should guide you no matter what you're doing with a child with ASD, and they include quality of life. If you're sick and you don't get medical treatment for that, your quality of life is pretty poor. If you suffer from migraines and you don't have medication to help you with, certainly your quality of life is very poor. If you have strep throat and you don't get medication for that, certainly your life is pretty poor at that point. You can't even swallow, you can't even drink. No matter what it is this child is dealing with medically, we need to understand that he needs medical care, and he may be at a disadvantage because he cannot communicate as well as the next child. Again, augmentative communication strategies are very important here. We need to be able to have the child point to a picture or a part of his body and explain that something hurts. And the reason why this is important is 33 to 80% of children with chronic medical problems are considered picky or problem eaters. 33 to 80%, let me say that one more time, of children with chronic medical problems are considered picky or problem eaters. Only 12% of these children have purely behavioral issues. Let me say that one more time because it's really important. Only 12% of those children have purely behavioral issues. The rest have medical challenges going on that we may not know about. So if you skip the medical intervention part of this, your plan looks a little bit like this pail. You have holes and it's going to fall apart. Trust me. We need evaluation, not assumption. If we look at this picture, we can say, well, he appears pretty healthy, right? This was before Ewan was diagnosed with eosinophilic esophagitis. He looks like a pretty healthy kid. He's not underweight. He doesn't look like he has any major problems going on with his skin or anything else that stands out as a problem. But we cannot just assume that a child was healthy. Children with ASD don't always communicate pain or illness or challenges that they face in their day. For Ewan, when he was younger, the first clue that I had that something was wrong is that he had difficulty nursing. Then we also noticed that he had reflux, that it was not controlled with regular reflux meds. We noticed that he developed dysplasia or trouble swallowing. And of course, we noticed that he didn't want to eat anything. His foods were things like Pop-Tarts and popsicles and chips, and those were the few foods that he did eat. We knew we had a problem in here, but we didn't know exactly what to do or where to go. And it wasn't until he was older when we found out that there was something else going on. In this next video, this is when our big aha moment occurred. This is when we did know something else is going on. We need a little bit more help than where we are at the time.
Can you say yay?
I don't want to say no.
You got a whiny voice today. Can you say yes?
No.
Are you not wanting to do that today?
You don't want
Let's see
any
if Chris
candy
can
today?
say. Hey Chris, can you say yes? Yes. Cool. Can you try it?
No.
Say yes. Do you want a piece of your candy?
Yes.
Okay, tell Mom, say yes.
No.
Can you say yay?
No.
You can do that. Yay! Hold your hand up.
No.
Yay! It's fun to swallow. I can feel my swallow. I put my hand on my neck, right here. And when I swallow, it goes all the way down to my tummy.
No, you don't do that.
Okay, I'll touch my neck. I'll touch my neck. And it goes all the way down to my tummy. Where's your tummy?
Went back down to mine.
Yeah, it goes way down to your tummy. Okay, turn the page. I like to swallow. What do you like to swallow? Do you like to swallow Sprite?
I don't want to swallow nothing.
You don't want to swallow anything today?
No.
How about your water? Good job. So today Ewan likes water. And he also likes Sprite and juice and chocolate.
Chips.
Chocolate chips? How about chocolate milk?
Chocolate milk.
Yeah, I like chocolate milk too. And you like to drink with what's this called?
Water. Water.
Yeah, you like to drink water through a
straw.
straw. All right.
Oh,
It's okay.
I want to go back home.
Do you want to sit a little bit longer? Are you all done?
So in that video, you saw a lot of things. What you didn't see at the very end there was Ewan walked over, came and sat on my lap, and threw up all over me. Now obviously that's a big red flag that something's not right. But throughout that video, if you don't focus on the things that he says, which sometimes are cute and sometimes are funny, sometimes are sad when he says, I don't want to swallow nothing, if you focus on what he doesn't say, that's more important. Throughout that video, if you look one more time, and normally I would show this video again, but you can see the the nonverbal communication that's going on there. You can see the grimacing, you can see the cheeks puffing up. You can see all the clues that something really is happening internally that we can't really figure out. And I sent this video to one of Ewan's feeding team members at the time, and she watched it and within 5 minutes sent me back an email saying, this child needs a scope. And it was shortly after that that Ewan did have a procedure to go in and look at his esophagus and scope and biopsy and found out that, yes, he does indeed have something going on there. But sometimes it takes a set of eyes, so observation really is your greatest tool. You need to see the big picture. We don't want you to ignore red flags. There are important red flags such as vomiting or retching, obviously, heartburn, diarrhea, colic, spitting up, gagging on food, choking or coughing, difficulty or painful swallowing. Usually you'll see a grimace when they try and swallow. Congestion, frequent congestion, colds, fevers, upper respiratory infections, constipation, pneumonia, a rash, hives, a lack of appetite, food sticking in the throat, noisy breathing or wheezing, and snoring and mouth breathing are all big red flags for the child with ASD, or really for any child for that matter. There are indications for referral to find out a little bit more what's going on in different situations. There is a need for referral if the child is refusing food. If he has extreme selectivity. Most children with ASD tend to hover around the I have 20 foods in my repertoire. I'll eat about 20 foods. Some children have less than that. Some children have 10. Some children have 5. Some children that I've met and worked with have 1. Certainly, if this child has extreme selectivity in terms of 20 foods or less, we need to kind of figure out why, see what's going on. If this child is tube dependent or accepts little by mouth, has behavioral problems, doesn't drink very much and has poor hydration, or has failure to thrive and has poor intake overall. If he has significant respiratory issues or oral motor or tactile problems, gagging is one of the big ones. If there's any delay in development of feeding skills, or if he's consistently missing 2 or more food groups, these are all an indication for referral. An urgent referral is a little bit different though. If we have a child that's aspirating at any time, has failure to thrive, or severe dysphagia, those are all an urgent referral. Aspiration is basically when you aspirate food or liquid into your lungs. Failure to thrive is obviously not meeting their goals for height and weight. And severe dysphagia is an inability to swallow to an extreme degree. Sometimes if you try and swallow and you have severe dysphagia, that food ends up in the wrong place, i.e. your lungs rather than your stomach. Those are all reasons for an urgent referral. Non-urgent referrals are things like sensory issues. Almost all children with ASD are going to have sensory issues whether or not they're at the table. But certainly if they have challenges with certain foods because of sensory issues, they may need to be seen, but it may not need to be urgent. Aversive feeding habits, they don't like to eat certain foods. Maybe they go on a food jag, which means they eat the same food over and over and over and over again, sometimes for 2 weeks or more. All children go through food jags. It's part of typical development. So your typical toddler may have the time period where they want to eat nothing but peanut butter and jelly sandwiches. The same thing is true for children with ASD. However, they may go on a food jag for a lot longer. Sometimes this may be months or even years. Some children have reflux, whether that's the child with ASD or not, but certainly children with ASD can have reflux just like anyone else can. Vomiting, dysphagia that's not severe, and rumination. Rumination is basically being able to bring up the stomach contents or acid reflux and then put it back down on sort of command. They can do it at will. They basically are swallowing stomach acid. They'll bring it up into their mouth and then swallow it. It certainly is a need for referral, but not necessarily an urgent referral. Medical evaluation really requires a team approach. It's not just one person. It's not generally just your pediatrician or your family physician. It's not just your school, and it's not just the therapists that work with your children. It's everybody. Everybody is part of a medical evaluation. They all have a part to play in this. Children act differently and do things differently at school than they do at home, and vice versa. Sometimes speech therapists can see things that pediatricians miss. Everybody works together to create a comprehensive medical evaluation. In terms of feeding teams, you don't necessarily have to see a feeding team. You can put one together yourself. This would include a pediatric GI, a dietitian, a speech therapist, an occupational therapist, sometimes pulmonology, sometimes social work. Obviously parents are involved in that. Sometimes we see things like cardiology is involved, or neurology, or ENT. Sometimes surgery is required. Sometimes we need endocrinology. Sometimes we need radiology or genetics to get involved. As you can see, it's not just one person or maybe even 2 doctors. Sometimes it takes several people to get involved and give us a bigger picture of what's going on. But we don't always have to assume that we have to visit an already established feeding clinic. Sometimes you can get quality medical care by piecing this together yourself. Sometimes we all live in, we tend to live in rural areas and we are maybe several hours or several states away from an established feeding clinic. There are still ways to get a medical evaluation without going to that several states away clinic. One of the most important steps that we can go through, though, is the nutritional history. You don't want to skip this step. You want to make sure that you know exactly what this child is eating. A lot of times I've asked parents, well, what does he eat? And they'll say, he doesn't eat anything. I'm like, well, does he eat? Does he really not eat anything? Or are we missing what's going on throughout the day and we kind of forget what he has eaten? Sometimes we'll take a food log, we'll write down exactly what they eat, and we'll find out they are eating a little bit more than what we thought. Or we may find out they're drinking more than they're eating, which is a common issue for children with ASD. So what we really need to do is evaluate, not assume. We can look at this picture on this slide of my son, and we can say, he appears pretty healthy, right? After all, he doesn't look very sick in this picture. I bet he eats enough. But assumption isn't good enough. We need to evaluate. We need to know what we're dealing with here. When we did a food log for Ewan, we found out that he was basically drinking all of his meals. All of his calories came from liquids. When we took down everything that he ate and drank for 3 to 5 days, we realized that this child was drinking 40 ounces or more of milk every day. Now, I wouldn't have thought about that. I would have just said, well, I made him a drink in the morning, at snack time, at lunch, maybe at snack time again, maybe at dinner. And I really wasn't considering how much was going into that cup and how many times a day he was drinking that. He was drinking far more than he was eating, which is a clue for children with ASD. The child with ASD often drinks more than he eats. We don't really notice that until we write it down. And one of the reasons we see children, whether they have ASD or not, drink more than they eat is because they may have reflux. They're trying to put out the fire. So they drink and they drink and they drink because technically their esophagus hurts. It doesn't feel good. So they drink to try to make it go away. Nutritional histories provide a really crucial element to the story. It tells us what they are eating or what they aren't eating. Sometimes we don't know that they're missing 2 or more food groups until we actually write down what they are eating. Sometimes we don't realize that they really only are eating 10 to 12 foods over the course of a week. So food logs really do provide something crucial to this bigger story, that big picture. We know that problem eaters usually only accept less than 20 foods and exclude entire food groups. We know that nutritional deficiencies are a concern and they can actually change how food tastes. Growth assessments are often required for every child when they go to the doctor visit, but certainly as we're looking at the child with ASD and determining whether or not they have other challenges going on, growth assessments are absolutely required. We need to evaluate individually. Formulas and charts don't always tell us the whole story. So while we need growth assessments and we need to know if he's growing or if he's gaining weight, we also need to know other things besides what's on that chart. Parents often worry though. If you think about it, when children are infants, we feed them constantly. We're constantly feeding babies. Every 2 hours, most babies need to eat. Well, as babies grow into toddlers, parents are still thinking babies need to eat 2 hours every day, every 2 hours, except that toddlers don't really need to eat that much. They don't grow as fast as infants do, so their appetite decreases dramatically. And parents aren't really ready for that step yet. They're still ready to feed this baby all the time, even though this baby is now a toddler. So we have to remember that children really need a balanced diet overall, but it may not happen every day. Each and every day for toddlers are going to be different. Some days they may eat very well, and some days a toddler may eat very little. And most parents get worried on the days that they eat very little. But really what matters most is what happens over the course of a week. If we see a toddler that's eating, good one day, not so great the next, pretty good the next day, not so great the next, we're going to take an average of that and see how they eat overall over the course of a week. Parents are often really busy. Sometimes we're often too busy for schedules. Sometimes we're eating in the car on the way to school or on the way to soccer practice or on the way to work, and we forget that schedules are really important, not just for children with ASD, but for all children. However, children with ASD really need schedules, and this includes food as well. If you remember, I said earlier, children with ASD may often not know when they are hungry or when they're full. And this is where a schedule becomes really important. If we know when we're going to eat every day throughout the rest of their life, we know that we're going to take care of when they're hungry and when they're not. And then the child then begins to learn that this is when we eat breakfast, this is when we eat lunch, and this is when we eat dinner. We know that it gives them time to empty the stomach. If we don't have a schedule and we eat a snack, and then maybe we eat another snack, and then we eat lunch maybe 15 minutes later, do you really think that child's going to be hungry if they've already had 2 snacks before that? Probably not. They're probably not going to eat very much. And we may not notice that they really are eating a lot unless we have a schedule and we're writing down what they're eating. We really need to become hungry again. This is why we don't eat breakfast, lunch, and dinner really close to each other. This is why they're actually 6 hours apart usually. We need time to become hungry again. If we're eating throughout the day, all day, we're really not ever really hungry. The stomach's never really empty. So this is why a schedule is really important. It gives us time to rest and recover. It encourages eating a larger amount of food at one period of time. And it allows us to eat more food rather than drinking more liquid. And we're not just grazing or nibbling on a small amount of food throughout the day. We're actually eating really good meals. It gives us multiple opportunities to offer food if a child refuses. So we can offer food at lunch, we can offer food at dinner, we can offer different foods at different meals. And we can kind of see what's happening. If we're offering little snacks throughout the day, we really don't know what this child wants to eat because they're really not hungry. We also have to think as parents, about what's on the plate, how much is on the plate. Most of us, whether we're at a restaurant or we're at home, are not using proper portion control. This is true for adults and it's true for children. It's true for all Americans, actually. We don't really know what a proper portion is anymore. Everybody gets supersized everything. But we have to remember the stomach is about the size of our fist. So we are going to have to realize that our fist as an adult is pretty big. We can fit a lot in here. If you think about a child's fist, though, it's much smaller, and we can't fit the same amount of foods that we can fit in our stomach as we can in theirs. So we have to remember that what we put on this plate has to be in proportion to their stomach size. We often put adult-sized portions on a child plate, and we think they should be able to eat that entire plate and finish the plate. What's the clean your plate rule nowadays, or it used to be? Children cannot eat that much at one meal, and nor should they be expected to. So we need to make sure that we're putting the proper portion on there to make sure that what they aren't eating isn't just what they can't eat because their stomach actually isn't big enough. We need to go back to the feeding history. We need to know exactly what's been going on with this child since infancy. Feeding histories begin the moment this child is born. Every child has a feeding history that goes back to the days of infancy and toddlerhood and preschool and child age and adolescent. This child has a feeding history for every part of their development. For Ewan, we had clues that there were problems with his ability to eat based off his feeding history when he was an infant, all the way from difficulty nursing from the very first days he was born, to reflux when he was a child that didn't go away on the medication that we gave him, to having trouble swallowing, whether it was swallowing food or swallowing liquid. Those were clues that something was going on, and certainly the fact that he didn't eat very many foods at all or had a feeding aversion was a big clue. At every point in his development, we had one of these clues going on, but we didn't quite understand the bigger picture, and it wasn't until we took that video that we saw earlier that we really saw that bigger picture. So every child has a feeding history. We need to know how did the child nurse or bottle feed as an infant? How did the child handle a transition to baby cereals or table foods? How did that child handle the transition to bottles or cups? Did the child ever learn to use utensils like forks and spoons? Is the child able to chew a variety of textures? Are there settings where the child does eat really well? Does he eat well at home? Does he eat well at school? Maybe he eats really well at grandma's house. We need to examine that and see why. Are there settings where the child simply does not eat at all? One that comes to mind is the school cafeteria. It is one of the loudest, most chaotic environments I think that is ever known to a child or adult. Certainly I think the EPA probably needs to come in and check the noise regulation for most school cafeterias. They are very chaotic. How available is food to the child? As we said earlier, there's a schedule for a reason. Sometimes children have food that's available to them all parts of the day. And sometimes they even get up in the middle of the night and they have access to food. We need to know how available is food to the child. Is the child on a schedule for eating? How does the family approach food? Sometimes we notice that mom doesn't eat very much, or dad doesn't eat very much, or dad has a very strict policy with eating, that it is a clean your plate rule at his table. Sometimes we notice that, mom and dad don't like certain foods, but yet they expect their child to eat those things. Why doesn't he like carrots? Sometimes mom doesn't like carrots. Sometimes there's another family component that we don't often think about. Has the child ever enjoyed eating? And this is really important. Has this child ever looked at a meal as something enjoyable? Has he ever wanted to eat? Has he ever been able to eat without a grimace or without being upset or without being aversive to some aspect of the meal? Is there a consistency between parents during the meal? Sometimes parents often disagree with how much the child should eat or what they should eat or how they should eat or how they should learn to eat. And we need to know what mom and dad both think about this and try and get everybody on the same page. If just one parent doesn't believe that in a certain thing, we're going to find that whatever plan it is that we have is going to fail because they're not going to be consistent. In this next video, we're going to see some red flags. We're going to go through this video and I'll show you some of the things that you might notice. In this video, this is my son, Ewan, and his younger brother, Vaughn, at a feeding therapy session. Now, Ewan is the bigger child over here, and Vaughn is the younger one. In this video, you'll see that they're trying out some new flavors and dips. They have chicken and they have honey and some other things that they can dip to try. You'll just notice Vaughn just smelled the honey and now covered his face. He thinks it smells terrible. You can look at Vaughn and he's starting to worry. You can see him stress out about what we're going to eat. You can see quick little nonverbal issues where he's starting to get really stressed. He's starting to rub his head, pull at his shirt. He seems very uncomfortable right now. And Stacy, the speech therapist, is asking him to try something. You can just see he does not want to try it. And he's moving away. He physically moves away. In that video, you could see more of what we would call sensory challenges. Now, Vaughn in that video does not have ASD. His brother does. But I always say Vaughn has a lot of issues in terms of sensory problems and some of the social issues that you might see in a child with ASD. He shares some similarities with his brother. But as you can see, some of those sensory issues are pretty strong. He couldn't handle the smell. He actually had to cover his face. Some children will actually gag just from the smell of a food. It's enough to send them over the edge. Sometimes it sends them running from the table. What you don't see in this video is that Vaughn does not participate the rest of the time. He does not want anything to do with trying some of that. In this next video, we're going to see some more big red flags, and I'll point them out as we go. In this video, Vaughn and Ewan are trying some foods again, and we're trying apples and bananas, and we're dipping them in powdered sugar and chocolate syrup, and we've also got some marshmallows on the side. So we're having a little bit of an experiment here, trying different foods. Now if we watch Ewan, we'll see some nonverbal clues that there's something going on here. They're both dipping and tasting. Oh, there was a little bit of a grimace. Oh, now we've got some syrup on our hands and we have to wipe everything off. Did you see there's another grimace there? Taking another bite. Ewan's is talking about how he likes the dip and how he likes the apple in this video. Here his brother shoves him. Here Ewan takes a bite of an apple. Oh, there's a grimace. That means something. Uh-oh, something looks like it's wrong. There he gagged. Now it looks like it's getting stuck. And he swallowed it. So as you can see in that video, there were a lot of clues that something was wrong. We could see that there were several grimaces. There were several times where he stopped, and he paused, he gagged during a swallow, he touched his neck to say something's stuck. Those are all clues that something's wrong. But when you watch that video with the audio on, you get an entirely different picture. You're thinking about what they're saying. Sometimes it's funny, sometimes it's cute, and you're not focused on what they're saying with their body. I always tell people the best thing you can do is take a video and turn the volume down. You see a lot more of all of those grimaces and those swallowing challenges with the volume off than you do with it on. In this next video, you're going to see Vaughn and Ewan at another, actually I think this one is just Ewan. He's in a speech therapy session, another feeding session, and they're dipping strawberries and bread and marshmallows and chocolate, and they're trying different tastes. Here's Ewan with his speech therapist. He's jumping around and they're doing some fondue dipping. You can see Ewan has a little bit of trouble getting the strawberry on the stick, and he's able to dip, but he doesn't eat it. He puts it on the plate. Oh, he's not sure about this. He's telling someone else to eat, but he doesn't want to take a bite yet. He goes ahead and gets another strawberry here. A little bit smaller. And he takes a bite. He actually puts the whole strawberry in there, which is really overwhelming, you can tell. Oh, now we're not sure what we did. We're not sure if we like it. It's a little overwhelming. But he smiles. Seems a little bit happy. He tries another one. All of those things are clues as to whether or not we would push more strawberries or we'd take a break. There are little things about taking the big bites where he maybe had a little too much in his mouth. We'd want to take smaller bites and things like that. But these are all clues that how that they enjoy a food or whether they don't, and whether we should keep going or take a break. Again, feeding history is important. It's important for a reason. It helps us figure out the facts, whether this child knows how to predict what they're going to eat on their plate, how that they're going to sequence through a meal. It helps us know if they know how to handle certain parts of the meal, whether that means taking little bites, how to use their fork and spoon, all of these things that are part of just eating a regular meal. A feeding history also tells us maybe there are clues to illness or pain in the past. You know, going back to infancy is where it all starts, and that's where every feeding history, no matter whether you're working with a 2-year-old or a 12-year-old or a 20-year-old, we want to know what happened when they were an infant. We want to know all those questions earlier about transitioning to cereals and transitioning to table foods, or how they went to using a cup, and whether they use utensils and all of that, whether now or even in the past. Changing the way a child with ASD views food and eating is a really slow and it's a deliberate process. The child didn't become a problem eater overnight, and to be honest, we're not going to fix this problem overnight. The problem evolved over time, and it's going to change over time. I always tell families there is no such thing as a magic wand when it comes to changing how a child views food and eating. It's not as if we can go into a feeding clinic and expect that person, whoever's running the clinic, to say, you know what, by the time he leaves here next week, he's going to be eating everything that there is. He's going to be the child like Mikey on the commercials that eats everything, and he likes everything. It's unrealistic. Like I said, the child didn't get here overnight. They're not going to get out of here overnight. This is going to be a long-term, slow process. Remember, context is everything. The child with ASD views food in a very different way. They often don't understand what's on their plate, and we have to explain and educate about what it is, where it came from, what it's going to taste like, and what it's going to, what kind of meal we're going to have that day. As we learn about the hows and whys of problem eating, we really must turn to explaining food and educating the child about eating meals and going out to eat, whatever expectation it is at the meal. We really have to explain those things step by step to the child. We talked about earlier using social narratives, social stories, and sequencing and hand over hand, all about explaining and educating to the child what eating is and why that we eat. These are all really important things that we take for granted as adults. We've learned what food is and why that we eat and what the expectations are over time. And we forget that the child with ASD doesn't have that same experience. So it's important for us to take the time and educate the child on what food is, where it came from, and what it tastes like, and so on. One of the tools that we have used is called food chaining. Now, there are multiple feeding programs out there, and I'm not saying any program is any better than the next one. They're all different for a reason, because we're all different, and the way that we approach food and eating is different. So no, it doesn't matter which program that you use, it only matters that you choose a program. For us, it was food chaining. Food chaining is really about flavor mapping, which takes what the child does eat, and it says, well, why do they like these particular foods? Is it the flavor? What about that food do they like? So it takes a food log and it examines what they're eating. And from there, we use things like transitional foods. Transitional foods are the foods that they already are eating. We don't take those away. A lot of times when you enter feeding programs, the first thing that they want to do is take away the foods that they're already eating. That's the last thing that we want to do. We want to build on the foods that they are eating. And we build on that through flavor masking sometimes, which is using dips or changing the flavor a little bit so that the child can adjust to a new food. If you've seen in many of the videos, we used a lot of dips like chocolate syrup and honey and things like that to mask the flavor of a new food until they were used to it. But a really big part of food chaining is food education. It's explaining all about why that we eat and how that we eat and what food is going to taste like. And we take all that information and we help the child feel comfortable with food, because there's a lot of anxiety about what's on the plate and what I have to do. But we only do all of this after a thorough medical evaluation. And that includes a nutritional assessment, it includes a developmental and a feeding assessment. It doesn't matter which program that you use, but certainly with food chaining, you need a thorough medical evaluation before you do anything, Because just like I showed in that picture with the pail, if you don't address medical concerns, it's not going to work and your plan will fall apart. Food chaining uses what the child already eats and expands outward, like I said, using flavor mapping, flavor masking, and transitional foods, while using food education to teach the child what to eat, when to eat, how to eat, and why we eat. Finally, on this last slide, you will find more information about food chaining in the food chaining book called The Revolutionary Six-Step Program to Stop Picky Eating by Sherry Fraker, Mark Fishbein, Sybil Cox, and Laura Walbert. If you want more information about food chaining, including the medical evaluations, you'll find it all in this book. However, this is not the only program out there to address feeding challenges in children with ASD. There are many programs available. The important thing to remember is every child has a story, and in order to fully help the child learn to enjoy eating, we need to ask why. Why doesn't the child eat? What's going on? We need to ask a lot of questions, and we need to ask them often. Thank you for joining me today. I hope some of this information helps you and your child learn to enjoy eating.